Hi everyone, thanks for joining us. So here at the International Consortium for Communication in Healthcare, we're going to be producing a series of short videos or spotlights, which literally do just that. They shine a bit of a spotlight on IC4CH members and the kind of work that they're doing. So I'm Gavin Brookes from Lancaster University, and today I'm fortunate to be chatting with Slade and Liza Goncharov, who are the Director and Deputy Director of the Institute for Communication in Healthcare at Australian National University. So thank you both so much for joining. So first of all, Di and Liza, within your roles within the Institute for Communication in Healthcare, I know that you're involved in running lots of different health communication projects. So could you perhaps give me a quick overview of your current projects, your current work?
Hi, Gavin. Thanks. Yeah, as you mentioned, we do have a number of different projects running at any one time. At the moment, our two major projects, I think, are the ones we might talk about today. So one project is on end-of-life communication. So this is a body of work that we started a few years ago, and it was actually brought to us by one of our clinical colleagues who's an intensive care specialist, and she came to us with a problem that she experiences as a clinician, that by the time she sees patients in the intensive care unit, she's making very difficult decisions about how to treat them. And at this point, the patients in the intensive care unit are often actually unconscious and unable to talk about what it is, what choices she should be making. And she says that she told us that this made it very difficult to have effective communication because the patient can't speak, and often the patient's family have not had a previous conversation with that patient about what they would want in the case of serious illness. So this kind of kicked off a big program of work. We did a couple of small pilots at Canberra Hospital looking at communication in the intensive care unit and then in the geriatrics and respiratory wards, really trying to understand what happens in this communication. Why is there such a lack of communication until late in the patient's health journey? And what can we do to try to improve this so that patients get better care? So the project that we're currently working on is a development from this program of work where we realize that we need to focus on a patient's journey through their health illness. So we're focusing on patients with cardiovascular disease and we're going back sort of a year before they're likely to die and trying to understand what communication do they get for that year. So this is really intended to help us to understand why is it that so often patients end up really close to death without ever having had an opportunity to talk about what they would want at that point. So we're hoping in this project to get a really thorough understanding of what happens along the patient journey, and then also to develop an intervention to try to improve this communication for patients and their family members. And I might hand over to Di now to talk about our other major project.
Thanks, Liza, and thank you very much, Gavin, for organising this. It's a great initiative from the now Lancaster-led Institute for Communication in Healthcare. So our other project, a major project at ICH, is entitled Improving Communication to Enhance Patients' Health Literacy, Empowerment and Self-Management of Heart Failure. So it's particularly focusing on heart failure as a very typical and prominent chronic condition, but the findings we expect to be applicable across a range of chronic conditions. It's funded by the Ramsay Hospital Research Foundation, which is one of our largest healthcare philanthropic organisations in Australia. I'll just give you a little bit of background on chronic heart disease and heart failure. It's the leading cause of death worldwide. In the United Kingdom, it is the most common cause of premature death and is responsible for the deaths of an average of 190 people each day. In other words, one death every 8 minutes. Pretty alarming statistics. In the United States, a person dies every 33 seconds from cardiovascular disease. That is 1 in every 5 deaths in the United States is caused by heart failure. There are similar statistics in Australia, with chronic heart disease being a major cause of death and causing around 1 in 4 of all deaths. What's interesting about what we're particularly looking at as well in this project is people's ability and willingness to self-manage their heart failure. Because self-managing of heart failure with diet, lifestyle, medication, they're three of the major, can slow the progress of the condition. Yet only 50% of those diagnosed live longer than 5 years, which indicates a fairly, not a particularly high level of success with self-managing. So it suggests that many people face barriers to self-managing their condition. Now, what's self-management got to do with communication? Because our area is communication in healthcare. To self-manage effectively, people need the communication skills to source, understand, evaluate, and apply knowledge about their condition, that is their health literacy, but they also need to have the motivation and confidence to participate in shared responsibility of their care. Okay, which is it's a sort of slightly technical term, but is what is referred to in the health literacy literature. And Peter Schultz, who's on our team, is one of the most internationally highly regarded health literacy experts, and he's really sort of coined this term empowerment to particularly apply to a patient's motivation or person's motivation and confidence to participate in shared responsibility. However, people experiencing socioeconomic disadvantage with lower levels of health literacy and empowerment experience higher rates of heart failure and related hospitalizations and lower rates of evidence-based treatment. So really effective self-management is really critical, and if it's done effectively, it significantly reduces the adverse outcomes and also unnecessary hospital rehospitalizations and also patient distress, and also the escalating social and economic cost. So our whole goal is to try to increase patients, work out how we can effectively work with clinicians to increase patients' health literacy, empowerment, and their ability in particular to be empowering them to self-manage their condition. Okay, so what we're trying to do over a period, and I'll talk about the methodology in a moment, but we're describing, analysing and enhancing the communication practices of both clinicians and patients to support people to increase their health literacy skills and also their ability to participate in shared decision making.
Well, thank you. Those projects sound so interesting. Not only do they address really important health topics, but I think they clearly have potential there to contribute to more positive outcomes for patients and improving people's quality of life as they're dealing with different health issues as well. That's really clear to me. Di, a moment ago, you said that you'd like to speak a bit about the methodology. Maybe I could ask you both about that now. To do this kind of work, what sort of methodological approaches are you taking in these kinds of projects?
Thank you. I'll start with this, and then Liza will come in and look at the extension of our methodology we've been trying over the last 17 years. And it is a fantastic extension of it, in particular focusing on with a strong focus on implementation science. And she'll talk about her methodology with end of life. The Ramsay project, it's a mixed methods project. It's got a quantitative component that Peter Schultz has overseen, which consists of a survey for patients across our 2 hospital sites in Western Australia and ACT. So I should have said this, it's a cross-disciplinary team, a wonderful team of clinicians, nursing, medical, allied health, working closely with linguists and Peter, who's a communication scientist and a health literacy expert. Across those 2 sites, there's one private hospital, which is the Ramsay Hospital, and there's also one public, which is Canberra Hospital in ACT. So what we're doing, we're measuring 180 patients' health literacy, empowerment, quality of life, and knowledge of heart failure at admission and points 3 and 6 months afterwards. So what we're trying to look at is through that survey, we're trying to see to what extent are the patients, and these are in hospital patients, and then we recruit them in hospital, but then they go out to the community and go to the outpatients where we do the next surveys, what we're trying to look at is to understand really the effect of time and treatment on their increased health literacy and ability to self-manage. One would hope, wouldn't you, that the more appointments they have with cardiologists and with cardiac nurses and with their outpatient clinics, their knowledge and understanding of their condition and their health literacy about heart failure, you would expect to increase. And if it doesn't, then what we do is so in addition to that, to really try to get, because with these patients, we just give them the survey and they do that, and there's a validated instrument. But what we really, I think unusual part of what we do is, and the I think quite an innovative part of what we do is, and we've been building this up over 17 years, is we do the qualitative tracking of patient journeys. So we're looking at, we've done 180 surveys, and we now have got 40 patients. We're tracking their journeys up to 6 months to map the impact of spoken and written communication events on their health literacy, empowerment, and ability to self-manage. So what we're doing is we're looking at when they came in on admission, we get as many of their consultations they have, not just with the doctors, but with the nurses. We record as much as we can. Of course, we can't get it all, so it is partial, but we are there for many hours and we get as much as we can. And also, we try to get the discharge. Obviously, you miss some because they happen at night, or they happen without expectation, with no warning, so we can't sort of race in there to do it. But obviously, everyone completely consents to this. What we're really doing then is we are recording. What we're really interested to do then is we record, and then we interview the patients after each of the consultations and find out what they've understood, what they're concerned about, what their understanding of their condition is, etc. And we also interview the different doctors. That would often, and the nurses, that will often just be a quick conversation afterwards as they're racing from patient to patient. But you certainly get an insight even to that couple of minutes. So that basically then what we do, so that's the two major components. But what we also do, which is which just to explain our kind of the overall of our methodology, we go into the hospital context and we immerse ourselves in the context, like grounded theory. So we do detailed ethnographic observation and shadowing of participants. Okay, so we do that, and then we do what we call context interviews, and so We've done 61 context interviews across WA. They are with clinicians. We're trying to get a picture. Other projects we do patients as well. This one we focus on clinicians. What we're really interested then is what do they see as the issues and problems around self-management, around understanding and taking into account a patient's health literacy, but also more importantly, what are some of the system organizational change issues in their hospital context that is either enhancing or impeding patients' ability to be part of the shared decision making and participate in shared decision making. So we do interviews, we do audio video recordings of the routine naturally occurring interactions. We interview post-consultation. We also do an analysis of written documents. For example, all of the written documents that patients were given in relation to heart failure. Now, what these emerging findings give us is rich insights into the actual communication issues that impact the clinical encounters, and basically how both patients and clinicians can be supported to improve their communication. So I'll talk about the translation of it and what we do in a moment, but I think that, and Liza will talk about her methodology, but I think what is so there's three dimensions of our methodology that we think are really important. It's our teams are interdisciplinary. We don't ever do this research without the linguists working with the outsider perspective, collaborating with healthcare professionals. So all of our teams, from the CIs to the people on the ground, are a mixed team of clinicians with linguists. Now, the question that a lot of people ask, but the clinicians ask as well, is what can linguists do to help? Now, what's interesting about it is in all these 17 years, we very rarely have had clinicians not, after their initial bit sort of confusion about what we can do, not feeling really, not being really wonderfully collaborative and very supportive of it. But part of, I suppose, the quick answer to that is most of our experiences of healthcare is through language. That is, we can't do healthcare except through language. So it makes sense that so much of what goes wrong is with the communication process. So what we argue, Gavin, is that communicating care effectively is essential for delivering safe, quality care. Okay, so I will talk about the translation in a moment, but I'll hand over to Liza to talk about the methodology of end of life.
Thanks, Di. So Di covered, I think, our general methodological approach. So in our end-of-life communication project, we're doing a similar approach. Essentially, we are going to be collecting contextual ethnographic data, talking to clinicians, patients, managers to understand how the system for caring for people with cardiovascular disease near the end of life is working. And then as part of that, we then also record the actual interactions that these patients and their families are going to have with clinicians. And importantly, we're going to collect as many interactions as we can and at different time points so we can see how the patient journey through the health system from the wards to the intensive care unit into the community, how that goes and how the information is carried across all of them. So I think that's the majority of our current research methodology.
That's so interesting, and I really like that idea of the patient journey. You get that kind of longitudinal perspective, which you need to answer the research questions that you're doing, looking at end-of-life care, looking at patient literacy and empowerment over time. But at the same time, you've got kind of the depth of that kind of immersive approach as well, which you get really granular insights. So that's really interesting. Thank you for sharing that. You've mentioned, Di, the kind of about doing translational healthcare communication research. Could you speak a little bit perhaps about what that means in the context of the work that you're doing at ICH?
Thanks, Gavin. Yes, it's really what I call the so what question, that when you're working with clinicians in hospitals who give so much of their time and patients who I've only had once in 17 years a patient say who we asked. I mean, there'll be a lot of patients we didn't ask because we didn't think it was appropriate, like somebody who was too sick or whatever. But so we're very careful who we ask to consent. But once we've asked to consent, I've only had one patient say no. And then after he said no, the reason why was because he found out I was a professor at the same university that he was a professor at. And so he said, sorry, no. And that's all. It was completely understandable and amusing. So, but look, basically, what we're committed to do is to actually give back to the organisations and hopefully contribute to making even a small dent in terms of improving the quality and safety of patient care. So how do we do that? We basically move from collecting predominantly qualitative discourse data, but we often have a quantitative component, but we go from collecting the qualitative data through to the development and delivery of communication resources for patients and clinicians. So we do it's very intensive work. We transcribe verbatim the patient journeys or the patient consultations. There might be individual ones. This project's journeys. We transcribe verbatim, which is absolutely everything in it. We do a very simple transcription, which is readable and even the clinicians and non-linguists can make sense of it. We then we do a discourse analysis of, for example, what are the strategies the doctor used for shared decision making? What are the strategies I'm just giving very general examples that the patient used to insert themselves into the interaction, to question or to query, etc. So that phase lasts a long time, and based on that, we then develop examples of best practice. And also in one large project, we had videos made of verbatim reenactments of the actual interactions, and that was on nursing handover. And we've now trained hundreds of nurses across Australia and in Hong Kong. I haven't had one nurse ever say, "Oh my God, that's just not right. That's not like it. This is about bedside handover." In other words, when it's verbatim, exactly, it tends to be a very powerful training tool, because people can see it, because it is real. It's not made up role plays, and it's very different than made up role plays. Okay, so and that's why we do not just interview, but we actually record as well, because what people say in interviews is very different than what they actually do in real context of use. And so that's why those are powerful. But I'll just say one thing before I hand over to Liza, that really importantly, training alone does not result in sustainable change. So although we develop the communication protocols, we do the training, people love the training, especially ones with videos, but unless that is accompanied by ward and system level recommendations for changes. In other words, to change a culture of a ward or to change the communication practices, you really need to often change, and these ideas for system level changes come co-constructed from the clinicians. And I won't give you examples, but every time you go into a ward, there's of course room for improvement. So, for example, one example, Broadway is getting nurses back on the medical ward round, which is in one context. They were no longer able to be part of the ward round. And both the doctors and nurses wanted it, but it become a cultural change that they weren't. But when they realised the potential patient safety issues related to not being back in the ward round, that was one. That gives you an example of an organisational change that was recommended. We then go back in 3 months later and evaluate the impact of that intervention. So just to finish that, so what our kind of catch cry is improving communication practices across a ward changes the culture of that ward, and only then does the intervention impact on long-term sustainability and inclusiveness.
So just to add a little bit to that, as Di suggested, the methodology that Di developed over the last 17 years, as she said, comes very much from, the linguistic ethnography and functional linguistics. So very much a language model. And the approach to improving practice has also come very much out of that. But what I realized when I joined ICH 6 years ago now was that actually at the translational end of the research pipeline, which is the point at which we're actually going back into hospitals to try to improve practice, what we're doing is not really linguistics anymore. It's very much behavior change. And it turns out that there's a whole field, a relatively new field of research called implementation science, whose entire focus is on how do you develop interventions for the health space in such a way that they are implementable and actually achieve the behavior change that you want. So something we've been working on in the last couple of years that I'm really focused on in this next phase of our research is to bring together Di's methodology with implementation science to make sure that we use evidence-based behavior change theories to develop our interventions to make sure that they're as effective as possible to improve practice.
Oh, well, thank you. That's really interesting. It's kind of the work is motivated, I guess, by this kind of social responsibility agenda. You want not just to do the work and observe what's happening, but make a positive change to practice. And that's really clear. And I think that notion of bringing in implementation science, I mean, it just speaks to how interdisciplinary your approach is. And that's really interesting. That's something that I'll look at in close detail, I think, in the future, definitely.
Yeah, can I just say one thing in terms of picking up on what Liza said, very generously talking about Di's work? I do need to say absolutely here, and I want to put it out there, is that none of this would have been possible without my long-term 40-year collaboration with Suzanne Eggins, now Suzanne Rain. And she has been with me walking that journey every step of the way, designing the methodology, coming into hospitals and working out what works and what doesn't work. But also the marvellous and incredible Institute for Communication in Healthcare, which is what we have at ANU. It's called ICH. That's part of the International Institute, but that and the team there. So I wanted to acknowledge that it is a team-based approach and an international team-based approach, working with all of you lot.
Yeah, and that's really clear, I think, in the way you both talk about the work. I mean, there's so much involved. It has to be a team effort. There's no way that one or two people could do this kind of stuff.
That's right, exactly. Yeah. That's right.
So what's really clear to me from speaking to you today is that you're both really passionate about the work that you're doing. I think that comes through really clearly. Could you perhaps, as a final question, and then I'll leave you to go to for the rest of your evening, I know it's there in Australia, perhaps tell me a bit about kind of how you came into the field, what brought you into this area of work, and why you both think it's so important.
Sure. Well, Di tells a really compelling story actually about how this all started for her, which is, she came out of, there's a long history of the work that she did looking at communication in workplaces, trying to understand what was happening in different workplaces. She worked in lots of different places. And because I think, she's very motivated by improving exactly what you said, Gavin, the idea of being socially responsible and trying to use research to improve the world in some way. She realized that most impact improving workplace communication is actually in the health space, because that's where lives are really, really at stake. So I think that for me, when she told me that story, has really kind of captured the spirit of Di's approach to this research, and for me, why this work has been so interesting. And for me personally, I think I've had enough experiences as a carer in hospitals. Whenever you talk to patients and people who have been in hospital, the main thing that they talk about is often not actually their health concern, but the communication and the experience that they have whilst they're being cared for. So I think that's what drives me personally, and as a result, our institute really has a fundamental goal of trying to develop research that really makes a difference to the overall delivery of healthcare, so that the health system actually serves to make patients safe and feel cared for.
Yeah, that's admirable, I think. Yeah. And Di, could you speak to that same question? I mean, Liza said you had an interesting story, so she set you up here. You need to give me an interesting story now.
I think that she's done it for me. I think that I've most probably said enough, but and so no, Liza hit it on the head. So I suppose that also I've been very, very lucky in being at a couple of universities that really encourage this, because it's cross-disciplinary and quite unusual. And when we first set it up in 2017, it was Christian Matheson, who I should say was also the other person who went on this journey with me. He was head of department in Hong Kong, and he invited me to apply for a professorial position there. That was the first, and with Beth Ryder from Harvard University, that the three of us got together. She's a doctor, a pediatrician, fabulous, insightful, and so the three of us really started up that first iteration of a centre. So, and it's been really going from there. So, and then I came to ANU, Australian National University, that has been remarkably supportive. So, and we work very closely with colleagues in medicine. So it's I think I've been very lucky. It's an area of it's growing, as you know, don't you think, Gavin? It's becoming it's getting. It was a new area. It's still a new area, but I think it's increasing both its visibility, not only in social science, but also wonderfully and importantly in the number of wonderful medical and nursing and health science colleagues that we work with, and hospitals. I mean, so who are now asking, increasingly being interested in this kind of work across the world.
Well, thank you. That's a really inspirational and optimistic note to end it on. So I think we can leave it there. So I'd like just to thank you both so much for sharing all of that with us. Even though I've read your work and we meet every now and then through IC4CH and so on, I feel like I've learned a lot. So I'm sure that everybody watching at home would have learned a lot as well.